Well, let me pick it. Let's go. Did you turn on your mic? Just do, I don't remember what the...
Little side thing is on or off.
Yeah.
Is that better? Yeah, okay. That's what that.
In theory, it should at least be picking up. All right. So for NICU Journal Club today, we're going to be talking about the 2-year neurodevelopmental outcomes after mild HIE in the era of therapeutic hypothermia. I, not surprisingly, do not have any disclosures. So our objectives will be to identify the clinical question, appraise the article, and understand the currently known uses and limitations of therapeutic hypothermia, distinguish important factors in the determination of internal validity of the study, and then the external validity as well. So in terms of clinical context, so HIE is a major cause of neonatal death and disability. So it's estimated to be 1 to 8 per 1,000 newborns in developed countries, and then 6 to 9 of all neonatal deaths, that's premature and full term, but 21 to 23, so a very significant proportion of full-term children. So there are many, many risk factors. Just some of the ones that I've highlighted here: placental abruption, prolapse or a tight nuchal cord, uterine ruption, maternal shock and death, severe preeclampsia, infection, prolonged rupture of membranes, post-dates, growth restriction, and shoulder dystocia. So for the review of the pathophys for the non-neos, so obviously adequate blood flow delivers oxygen and glucose to the fetal brain, which allows it to function appropriately. The risk factors that we just reviewed, or any other issues that cause decreased perfusion of the placenta or decreased delivery through the umbilical cord, causes hypoxia, which in turn will lead to decreased cardiac output and then decreased cerebral blood flow. So decreased perfusion causes a sequence of injuries. So acutely, you'll have increased anaerobic metabolism, which increases lactic acid and decreases ATP, leading to excitotoxicity, release of oxygen-free radicals, and eventually cell death. Partial recovery after 30 to 60 minutes of the acute insult leads to the latent phase, and that may last 1 to 6 hours. And during that phase, you have more oxidative metabolism, inflammation, and apoptotic cascade. So then the secondary phase occurs in those with moderate to severe injury 6 to 15 hours later. And this is where you'll see mitochondrial failure and seizures, and then the tertiary phase is months later and has late cell death, remodeling, and astrogliosis. So a lot of experimental data suggests that mild hypothermia applied within a few hours, so no more than 6 hours after injury, is neuroprotective. The mechanisms, from my understanding, are not 100% understood, but could include reduced metabolic rate and energy depletion, decreased excitatory transmitter releases, reduced alterations in ion flux, and then reduced apoptosis due to the HIE. And then reduce vascular permeability, edema, and disruption of the blood-brain barrier functions. So therapeutic hypothermia is, generally speaking, the standard of care for neonates with HIE. You are cooling them mild to moderate hypothermia, so 33.5 to 35 degrees Celsius. It does reduce the risk of death or major neurodevelopmental disabilities at 18 months for moderate and severe HIE. And the best outcomes are when it's initiated within 6 hours of birth and continued for 72 hours. So with this article, as we go forward, I do, once we get past the kind of review of the structure of the study and everything like that, want it to be more discussion-based, because I don't think there's anything particularly shocking about this article in terms of new discoveries. But I do think that as we have more parents who are learning how to research on their own and look things up on their own, they're going to start asking about, why are these children getting this type of intervention and my child isn't? So I think being able to talk to them about what has been shown to help, what hasn't been shown to help, and what the risks are just as important as being able to provide the treatment itself. So I just included the pediatrics criteria at Carilion for therapeutic hypothermia. So again, they have to be full term, so greater than 36 weeks or greater than 1,800 grams, less than 6 hours, and then not have any major congenital abnormalities. There's also physiologic criteria, so that blood gas within the first hour of life has to have a pH less than 7 or base deficit greater than 16. There's a neuro section that we'll get to in a second that's part of that criteria as well. And then if you don't have that blood gas or the base deficit is kind of in that gray area, 10 to 15.9, but you have history of an acute perinatal event, so abruption, cardiac arrest, et cetera. They need either a 10-minute APGAR score of less than 5, or they needed ventilation at birth and continued for at least 10 minutes. So you can see in terms of their neurologic criteria, if they're having seizures, that's an automatic inclusion for them. Otherwise, they need findings in 3 of the 6 categories included here, which are consistent with moderate to severe encephalopathy. And it's a pick the highest level. So if they have moderate finding in one and severe in the other, that kind of pushes them into the severe group.
And just something to add on to what we'll do. So we have started pulling 35-weekers.
Okay.
I think right before Danielle and I came, like sometimes they would call other hospitals like UVA and such. Hey, what do you think about us pulling? I know Danielle and I have routinely pulled 35-weekers. I can't speak for the rest of our attending. And she and I have also intermittently pulled some 34-weekers.
Okay.
Hospital.
Do they have to be of that weight too, or not, or is it both?
Yeah.
Like it said 1,800 grams? They have to be both.
All right. So the clinical question addressed in this study, the population was children ages 18 to 42 months. The intervention was therapeutic hypothermia, and the comparison was no treatment at all. The outcomes that they looked at were the cognitive, language, and motor development in 18 to 42 months. And then the type of question was kind of therapeutic, and it was a prospective cohort. So in terms of the study design, it was a multi-center cohort study. The 4 cohorts were based at Cork University Hospital in Cork, Ireland, and then Karolinska University Hospital in Stockholm, Sweden. And then the dates of analysis were between September 2017 to June 2019. So the subjects were recruited prospectively to these 4 different cohort studies, and then that data was combined to be able to perform this. So children in these 2 studies, I keep wanting to call it BHIVE, but it's BIHIVE 1 and 2, were recruited at birth and had criteria either umbilical pH less than 7.1, APGAR scores less than or equal to 6, and then need for assisted ventilation or CPR. Meeting these criteria gave them the diagnosis of perinatal asphyxia, and then they were followed after that point for the development of HIE. And therapeutic hypothermia was the standard of care at both sites. So again, can you guys see that okay? It's a little bit tiny. So these are the 4 different cohort studies. You can see, well, generally speaking, the inclusion criteria are the same. So you have the BIHIVE study that has more specific criteria. The NEO-COOL study and the ANSWER-1 study just said, moderate or severe HIE. So depending on what they're, while generally speaking, definitions of HIE are fairly standard, depending on what other inclusion or exclusion criteria their particular hospitals or systems had, might have varied a little bit in terms of who was included and who was not. And I also thought it was interesting that the ANSWER-1 study had a requirement of EEG monitoring. So in terms of study design, the control groups, these were healthy babies, so uneventful deliveries. They had normal umbilical cord pH, normal APGARs, and normal newborn exams. The worst grade of encephalopathy during the first 24 hours was recorded for infants in all 4 of the cohorts. The treating physician is the one who assigned the score, and it was assigned using the modified Sarnat score without EEG. At time of discharge, the patients were categorized as either healthy, having perinatal asphyxia without HIE, and then mild, moderate, or severe HIE. And they did exclude children who had encephalopathy of other etiologies. So again, for the residents who are not as familiar with the Sarnat scoring, this is kind of a chart of how they do it. So you have your different stages, of course, in progressing severity, and split up into several different categories. So consciousness, tone, reflexes, sacral pupils, heart rate, secretions, GI motility, and seizures. So in terms of the exclusion criteria, so in total, there were 741 live-born infants that were recruited to these 4 cohort studies. Overall, between them, in the NEO-COOL study, 66 children were consented, 117 in the BiHype 1, 501 BiHype 2, and 30 of those ended up being included in the Answer 1 and then 87 in the Answer 1 study. So 51 children were excluded, 6 were due to prematurity, so less than 36 weeks. So again, that's kind of going back to, depending on what the inclusion criteria is for the cohort, if we treat some kids at 35 weeks, that would have been a group that was missed. 3 children were excluded because of lack of postnatal data, and then 42 were excluded because their final diagnosis was other than one of the things already listed. So 4 of them had had stroke, 9 had sepsis or meningitis, 7 with metabolic disorders, some had genetic disorders, and then 1 had a surgical condition, and 10 others had other causes of encephalopathy. So of the remaining 690 who are eligible, 471 children were followed up until at least age 2. 14 children died before age 2 years. 3 children, so 2 with PA without HIE and 1 with mild HIE, were not assessed because they had severe autistic traits. And then 6 children with severe cerebral palsy were not able to complete some of the testing, so they were not included as well. So in determining outcome measures, so they were followed up at between 18 to 42 months. So in terms of assessing their development, they used the Bayley scales of infant and toddler development, version 3. The average score is 100. Lower scores do indicate a risk of developmental delay, although I was trying to find some correlation between Bayley scores and future achievement or IQ. I wasn't able to find any good studies that really correlated those. So the mean group difference greater than 5 points was regarded as clinically significant. Development was considered normal if the Bayley scores, composite scores, were within 1 standard deviation of controls. And that was actually determined to be in accordance with other studies that have been completed previously. Severe motor dysfunction and severe autistic traits were recorded as severe outcomes. The language composite scores, because this was done in Europe, they did exclude non-English or Swedish-speaking homes, English or Swedish as a first language. And then children with mild HIE who were treated with therapeutic hypothermia and those with moderate to severe HIE who did not receive treatment were excluded as well. All right, everyone's favorite part, the statistical analysis. So in looking between the 2 groups, so the Kruskal-Wallis test looked for continuous variables. It's a rank-based, non-parametric test. Basically, it's used to determine if there's statistically significant differences between 2 or more groups of an independent variable on a continuous basis. So the mean Bayley composite scores and mean differences with 95% confidence intervals were estimated with linear regression, and then stepwise linear regression for other variables. So HIE grade, country of birth, maternal age, maternal work status, their education, gestational age, sex, and birth weight. And then independent variables with a P of less than 0.2 were entered into the multivariable regression. So what did we end up with? Out of the 471 children, 152 were the healthy controls. You had 185 with perinatal asphyxia without HIE, 134 who had HIE at birth. So 41% of those were mild, 42% were moderate, and 17% were severe. Just in terms of looking at the groups at the different hospitals, Cork Hospital ended up having more of the control babies, and those with PA without HIE and mild HIE versus Carilion tended to have more of the moderate and severe HIE. I mean, they weren't really able to account for that, any reason for that in the study itself. And then there was a significant difference between the median age of follow-up, so 23.1 months for the controls, and then 26.6 months for severe. And again, they didn't really have an explanation for that. They didn't talk about whether it was because they had those with severe HIE had more complicated medical courses in general, so had more appointments to go to, so it just took them a little bit longer to get there, or whatever the case may be. So, and looking at the outcomes, so looking at this table and comparing it to the groups with some sort of injury, naturally, not surprisingly, children with severe HIE have the worst scores. Those in the mild HIE category did have scores lower than the moderate HIE groups in terms of cognitive skills. And then there was kind of interesting to note there was no significant difference in the crude mean of the Bailey scores between children with mild HIE and those with moderate HIE. Conversations having with Dr. Pryor was we had more children who passed away in that moderate group, so again, you can't really account for whatever their scores may have been. So then this table really compares the composite scores of the controls and those with mild HIE, which is really what this study is kind of trying to tell us all about. So there was a significant difference in the mean cognitive composite scores of those with mild HIE. But in the adjusted and the multivariable models, the language and motor composite scores cross ones that are not statistically significant. So it's really just the cognitive scores that we're looking at in terms of significance. And then even when multivariable regression was performed, the mean scores between the control sample and the children with mild HIE did remain significant for cognition. So outcomes overall, the study, 219 of the 690 patients were lost to follow-up. And then survival with normal cognitive composite scores, again, not surprisingly, the controls had the best, and you kind of go in order of increasing severity from there. So the conclusions that the study drew were that children with mild HIE have significantly lower cognitive composite scores based on the Bailey scales compared with healthy controls, that there is no difference in cognitive outcomes in children with mild HIE versus moderate HIE treated with therapeutic hypothermia. Little guidance really exists for the clinical management of mild HIE, and then further research is needed to assess benefits and consequences of treating these children. So in terms of our appraisal, so were the groups similar? Yes and no. So we kind of discussed this already. While they're all able to be categorized into healthy control versus PA versus HIE, again, depending on the hospital center and how they defined HIE and inclusion criteria in general, because it's these 4 different cohorts, we don't necessarily know if there was some variation between that. Does anyone else have any other thoughts on the groups being similar, different? No? Okay. Aside from that, were they treated equally? So therapeutic hypothermia was a standard of care. One of the limitations that they noted, and I think is valid, is that the Bailey score is administered by different individuals at each center. Even though they had observerships, 5 observerships before they did this as part of the study protocol, I feel like anytime human judgment is involved, there's room for error.
Dr. Washofsky, I have a question online. They want to know, was this study of cooling versus not cooling? It wasn't?
No, it was cognitive outcomes.
Okay.
And then, of course, we talked about the patients who are lost to follow-up. So whenever you lose a significant number of patients to follow-up, you have to wonder what those scores would have been and how that would have informed the outcomes. The one thing that they did note was that the mothers of controls who were lost had lower grade of tertiary education. I don't know that that would necessarily inform a ton of the outcomes, but in all of these, they didn't really, and we'll get to this later too, they didn't really account for socioeconomic status or things like that. So, you know, the developmental outcomes of children is largely influenced by the environments that they're in.
And so, specifically with babies that have neurological deficits in the newborn period, and even in a lot of the studies that look at HIE and cooling, one thing that does show a better benefit is parental education. So that could be something.
Yeah. And again, we kind of addressed this, but the Bailey scores are what were used. Again, when any human is administering or interpreting a test, there's room for error or slight differentiation in how they interpret it. And so a lot of people came in a little bit later, but for me, I think one of the reasons that I liked this study or chose this study, at least as a discussion point, is that there was, as I said before, nothing shocking, no major new developments in the study, but we do have parents who are researching more about treatments that are available to them. And so for these children with mild HIE, I think it's important to be able to discuss that studies have been shown, have been done, so that when they ask why their child's not getting this treatment and other kids are, that we can have that discussion more on an educated basis with them. So in terms of similarity, again, it's a European study, so in terms of population samples, it's kind of unclear. And again, they didn't have any breakdown of SES, ethnicity, or other variables that may have contributed to these children's development. And then, will the potential benefits of therapeutic hypothermia outweigh potential harms? Again, further research is needed. Given that the mean scores are only points apart, does the potential for higher cognitive scores really outweigh the risks of therapeutic hypothermia? I think that depending on your patient population, there are going to be parents who want the extra cognitive points no matter what, and who may not, in their own way, understand the risks of therapeutic hypothermia. So I think that's one of the reasons that this conversation is important.
I think that's the big point with this article is when you looked at, they're statistically significant, again, only when you're looking at cognitive outcomes.
Right.
And like we talked about, you always want to look at your adjusted model, because that's what's taking into account your multiple variables.
Right.
It's only a couple points apart and from being the control group who were normal. So to cool a baby for 3 days, put them through what all you're saying, to maybe just give them a couple more points, and their scores were already normal.
Right.
Again, the normal range, to give them 3 to 4 points more on their cognitive outcomes.
Right.
It's tough to tell if it seems like unlikely to be clinically.
Right, and just as a point of reference, for the Bailey scores, a score of less than 85 is really what's defined as at risk for moderate to severe neurodevelopmental delay. So these kids are really not anywhere close to that. Some of the risks, your thrombocytopenia, subcutaneous fat necrosis, hypercalcemia, so there are risks associated with any treatment. Nothing is particularly benign. But I'm sure that at some point someone will run into a parent who wants to argue the point. Sorry, Dr. Andy Savage.
Also, as far as risks, it's kind of labor intensive to do the monitoring of the temperature, and babies can go too low, and that doesn't do them any good. So it's kind of a labor intensive and open for a lot of human error. So you just have to make sure that it's worth whatever benefits you're getting. I believe in therapeutic hypothermia, but my first case had a terrible coagulopathy, and that just made the whole thing very bad. So I have a bad flavor in my mouth.
And for you guys, coagulopathy is one of the potential side effects.
Right.
Yeah. So, and I've seen several babies with coagulopathy, and then we had to question whether to continue it or not.
Then you have to wonder, is the coagulopathy from the hypoxic insult, or is it from the coolant?
I think there's actually data that suggests that it's actually similar, but more likely from the HIE than the
But then the hypothermia can potentiate it.
Right.
So it can actually, significant coagulopathy is a contraindication to coolant.
Right. One of my biggest problems with moderate and severe, the baby's sick. But when you get to the mild, or I haven't seen before where they said perinatal asphyxia without HIE, but if you look at the Sarnat classification for mild, that could be a whole lot of babies, and it really depends on where you do it, what time you do it. You do it at 10 minutes of life, this baby could look terrible.
Who's been in delivery and seen a stunned baby?
And so that's mild encephalopathy at birth. We've all seen them with their eyes wide open. I don't think it's necessary to cool all those. I've had babies that I've sent to newborn nursery who I just was admitting, the next day and noticed their cord pHs were 6.9. Should I take them to the NICU? No, I'm not going to take them to the NICU. The baby looks great.
But that's what, I'm sure y'all went through the Sarnat stuff and our criteria. So you do have to have neurological set for it. So even if the gases are bad or APGARs are bad, if the baby looks fine, and we usually give them a decent amount of time.
And years ago we brought a baby up, and the baby just recovered, took the tube out, looked great within about half an hour after birth. And I said, well, no, we're not going to fool this baby. And at 5 hours and 59 minutes, the baby had a seizure.
Yeah. So that's the scary part.
Okay, and I was going to say, whereas a lot of us have been burned by the kids who go into DIC, a lot of us have also been burned by the kids that we thought about it, we're like, no, you actually look good, and then somewhere between 6 and 12 hours of life, and then you're kicking yourself.
Well, that's why I always say, if you're on the fence about it, cool the baby, because you can't go back and cool the baby.
Well,
If you're on the
we
fence about
don't
it,
know
you
that.
think the kid.
I don't know if there, I haven't looked at the studies lately, but I know that we're starting to look at how late can you cool and have an effect.
Right, there's no studies that have shown.
Nothing
Yeah.
recent.
And so, to get to Janie's point with the online question, the overarching thing they're looking at in the study is we know, like Lisa mentioned, there have been great studies showing there are benefits neurologically down the road to cooling babies with moderate and severe encephalopathy. This was looking at, should we cool babies with mild encephalopathy? Does that give them better outcomes? I don't think, with the study, I don't think there's enough to say that there is. It does lead us into one big study that's getting ready to come out called the HIE trial, which is looking at using EPO in babies who might not qualify for cooling, if they're too small, things like that, which the early reports are that it's going to have good data.
So you can tell, even our group is split, especially on those kids that are you mild? Are you just like a bad mild, or are you like a mild moderate?
And were you mild at 10 minutes of life, or were you moderate at 10 minutes of life? And, because I've looked several times for articles saying, when do you do the timing of neurological, because
And then that's
changed.
no one can agree on that.
There's
No one can agree on it.
It's
on the group practice, which was.
And
Sorry, the HIE trial was EPO in addition to cooling.
Okay.
Hopefully,
But I will say on the kids that we were kind of borderline on, sometimes we will talk, or usually we will talk to the parents about it on what we're debating on.
And if you're doing a 35-weeker, I would definally be saying we're doing this outside the.
And I would say that usually when we're doing something a little bit younger than usual, those aren't going to be your meh. Those are like your moderate to severe.
Yeah,
like,
those are
the only thing that will help your child.
because almost every place's guidelines will say one of the criteria to do is they have to be 36 weeks or greater, and almost everybody will cool down to 34 weeks if they're a decent size baby.
Okay, got another question. Then, for the endoside from the study, once cooling begins, how are other conditions monitored for? Seems infection and shock would be masked by cooling.
If you want to take a shot. That's okay.
I mean, I assume it's like anything else, their clinical status overall.
It's standard monitoring. I mean, we send labs on arrival, we follow them based on any abnormalities.
12 hours.
Yeah. Our nurses are really diligent about.
All of these kids are gonna get a rule-out
Yeah.
So they're on antibiotics for at least the first 48 hours of the cooling. They've got
Monitoring their
this screen. They get, a fair amount of additional lab monitoring over kind of even our micros. And they also, for the vast majority of them, we're putting in lines, and particularly the art line, even if they're fairly, quote, well from a cardiorespiratory standpoint and not needing a lot of support from that, we try to get the art line, and particularly the umbilical artery line, so we're measuring the aortic blood pressure. We're not measuring peripheral, because when you are cooling, normal cold physiology, you shut down your periphery. So capillary refill becomes less accurate, and cuff pressures become less accurate, and a peripheral art line is not going to be as accurate. So having that umbilical artery line during cooling is very helpful, because that's in the aorta. That's a true blood pressure. We also typically will place a buoy. Now, about half the time they end up being around it, and so we end up taking it out, but they are on strict eyes and nose the entire time they're cooling. As Lisa mentioned, this is a labor-intensive group. Pretty much throughout cooling, they are a one-on-one nursing assignment. It is only once they are rewarmed that they will go into a two-baby assignment.
I think one thing that's worth us looking into that some places have adapted is an early exit protocol. So at 24 hours, we'll say, if we don't think if maybe we decided to cool you, but maybe you ended up being a very mild case and you look like this is no benefit to you, or you're having side effects and we're trying to weigh the risk-benefit, places will get an EEG at 24 hours and kind of you discuss with another provider and say, do we think this kid meets criteria for early exit? Usually discuss with a neurologist, rewarm them then.
To that point, I think when you're looking at whether or not therapeutic hypothermia is helpful for the mild HIE, there's a black box warning against first ed use in the unit. And so if we're giving sedation to neonates to keep them calm for.
I'll agree with you on that one.
So that would make sense to look at early exit if we're having to sedate the child to be able to provide a treatment. But the question online, opposed to sepsis, the bigger concern I have, to mirror what Lisa said, is coagulopathy. Being very vigilant about coagulopathy. We've seen a child die because of coagulopathy, but once it's on your radar, I've seen babies get the blood products they need and reverse that in a timely fashion and be able to continue safely on treatment.
And along those lines with the first ed use, there's the Marble trial, it wasn't the main thing they looked at, but it was one thing that said if you have a baby on cooling and sometimes they'll end up on fentanyl infusions or opioid infusions. Those babies have worse outcomes long term than if you're just treating them intermittently or looking at ways that maybe that kid needs to come off of.
And some places they will do an EEG before they will start the cooling.
I think that may depend what's your availability of somebody to read that. Or even if they don't read it, if you have it.
We don't have it here, but some places will do an actual EEG, 2 1 hour EEG. There's red pattern in logic before they will decide that we have to cool the child.
Which also brings up the point that we do have 6 hours to start cooling. So if you're not sure, you don't have to start it in the first 30 minutes.
No, but the earlier you do it,
The better, but you can wait an hour or two, and we've seen enough babies who are coming from other places that just turn off the warmer and they're passive cooling and their temps are 32. So you don't want to put the baby at more risk by trying to do it too early or doing it in an uncontrolled manner. The other point I want to make, because I've seen it done, is you should never do death criteria or advise parents on an EEG until the baby is warm. Unless it's overwhelming, because baby cold, first of all, looks like snot. We've got one upstairs right now. Their skin is clamped down. They look terrible. But they're also not moving a lot. They need to be warmed up, and that takes, how long does that take?
6 hours.
6 hours?
but just in your Gen Peds stuff, y'all seen that, and especially if you've ever taken care of any drowning victims. You're not, cold and dead doesn't work, it's when you're warm and dead.
Yeah.
So it's the same thing with your therapeutic hypothermia. I know that's kind of.
Well, along their point, and to the question with monitoring too, one thing we do is we have our own bedside EEGs, so the amplitude integrated EEGs, which allow physicians to interpret them at the bedside without the help of a neurologist. It can be helpful. I think it gives you an idea what you're dealing with as far as what is his background activity like. Can I see seizure activity on this? We're far from neurologists, but it's useful for bedside monitoring.
But the patterns are
recognizable.
Very recognizable. There's actually just a little cheat sheet, little card that has it.
That even a neonatologist can read.
Right.
The card,
I think anybody can read it. It's so easy to read.
I have a kid who looks stone cold well, but really scary gases or delivery history and stuff. I'll sometimes even put that on and see what it looks like, and if it looks like it's suppressed, then okay, maybe move forward. If it looks normal, okay, maybe not.
But we're getting rid of our EEG machines as they
Got one that works right now.
One of them got broke and then.
and they're not getting
We
updated.
have one that works right now.
They're obsolete. And so we're not buying, they're like $40,000, so.
And we do not even know where the data gets stored, or even if it gets stored
I
in
don't
real
care, I
time.
just want to look at what it looks like.
It can be downloaded to a CD.
And then where does that go?
That should go with the patient's medical record.
Well, I know we had this big discussion with our group like a year ago. Is it worth keeping an AEG? But with our neurology coverage, again, we're now, I think DC Children's isn't reading EEGs for us. So our neurology coverage is kind of back to being spotty.
Yeah.
So now could we rediscuss, is it worth it?
I did work, I think a lot of kids in conversations during
Yeah.
She appreciated that, I think.
So this might be something that you would just know, but why do we
So it's not necessarily HIE, that could have been perinatal, it could have been from platelet abnormalities.
Like if they have a stroke, can't they have HIE?
They can, but a lot of
But it can
times
be
it's the
independent.
timing of it. I mean, if it happened a month ago in utero, cooling does nothing. So the problem with stroke is the timing is so unknown. You notice the symptomatology when they're born because that's when you actually see them. But most strokes are actually not at the time of delivery. They've occurred sometime.
Like abortion.
But well,
A what?
Right, but then that's, you've got an acute event. A stroke in a newborn is not considered an acute event, so the vast majority. So if you have a stroke secondary to the eruption is the acute event. You have a defined time frame.
so we talk about cooling HIE, but really we are cooling babies that are coming out encephalopathic. We are concerned about HIE, but we cannot diagnose them with HIE until after the cooling period, and really technically with the MRI. Although we don't necessarily have pediatric neuroradiologists that are reading our MRIs, and HIE can be very difficult to discern because it's global. But we get in trouble. I can't put a definite
Neonatal encephalopathy.
We can't say it's HIE from the get-go, even though we're pretty darn sure it is, because we have an acute event and whatnot. So kids with strokes, if you don't know about it prenatally, sometimes do get cooled. However, the therapeutic hypothermia may not necessarily help with them if it was a stroke for the reason that they came out encephalopathic, and the stroke had happened prior to whatever a delivery.
And there's sometimes other cases where they have some other neurologic insult and stuff. We see them, they look encephalopathic because they're neurologically abnormal. We cool them, we rewarm them. Shockingly, they don't look any different 3 years later. Shockingly, they don't look any different because they have an underlying. And sometimes that occurs with a stroke as well. If we suspect there's an acute event, we will go ahead and cool them. The other thing with a stroke is a lot of times in neonates it can be secondary to a coagulopathy.
Well, and PL1A1, I never did, right?
Yeah.
Antibodies where
And stuff, so you do
mom
have
has
to be
negative
careful
antibodies and the
with
baby's
neonates that it's not because of a coagulopathy that they had it. But again, if there's a concern that it's an acute event, but you get a kid who's neurologically abnormal, but then, their birth history was stone cold normal. Their core gases are stone cold normal. This was likely an event that occurred hours, days.
Or it didn't have anything to do with hypoxic.
Yeah. And not, but a lot of it too is it's an acute event. We have 6 hours to do this. The therapy has to be started right away. So if it's something that happened some undefined time period ago, that's part of the criteria for cooling is evidence of an acute event. That's why the gases. I am very, if I have concerns about a baby, I'm like, please get me the gases. I want to see the gases. A lot of times in the delivery room, that determines my course of action for a kid who
That's
I
why
have
people
some
come up to me and show me this.
uncertainty about it. Probably. They forget you have shorter hair than I. I mean, I'm not that neurotic about it, but I mean, if things aren't going well and it seems like there's an acute event, gases are a big factor because they really tell you something about acuity. If they're so normal, this was not an acute event.
But doesn't mean they can't, if it was a very acute event, the gases may not have had time to change, but they still could benefit from cooling.
Right.
And to your question, we talked a little bit in didactics yesterday. If it's an ischemic stroke, you don't want to do anything that can anticoagulate, which is why I think they're excluded, because they're at much more risk of bleeding into that stroke. I think that's why they do.
I have a question. How long is the cooling period? How long do you, on average?
72 hours.
72 hours? Oh, okay.
And they've looked at studies where they said if you cool them longer, they looked up to 6 days, didn't show any benefit compared to 3. They looked at studies if you cool them deeper, where you turn them, they're 33 to 34 degrees now, if you turn them down to 30, didn't show any benefit, more side effects.
They've looked at body cooling and head cooling. We do body cooling.
I was going to say, some of those studies show minor differences, but those tend to be minor. there's been some discussion in the past of doing shorter time sprints, like 48 hours. That I'm not sure if we've seen any, does anybody know?
No, I mean,
Shorter time frames?
I think everybody's standard of care is still